his fellowship training eliminates the learning curve for lap hernias, and Tiffany Cox is going to present that. Thank you.
Good evening. Thank you to SAGES and the moderators for allowing me to present today, and all of you for staying around. I have no disclosures. Every year, there's approximately 600,000 inguinal hernia repairs performed, with a vast array of techniques available to do these procedures. When a surgeon is trying to decide which procedure he'll use, sometimes the learning curve could affect the ability of him to be able to choose what he would want to do as to how he would achieve mastery for that type of procedure. The VA study in 2004 stated that surgeons who performed greater than 250 laparoscopic hernia repairs were able to achieve the same outcomes as open anterior repair. This set the benchmark for laparoscopic inguinal hernia repairs to state that they would have similar outcomes from complication rates. A study on the Roux-en-Y gastric bypass also showed an elimination of the learning curve for the laparoscopic approach through fellowship training. We theorize that MIS fellowship training with expert surgeon mentorship can eliminate the learning curve for laparoscopic inguinal hernia repairs. Our objective was to evaluate the initial post-fellowship cases for laparoscopic inguinal hernia repairs by fellowship-trained surgeons at our institution. 2 MIS-trained surgeons were evaluated, and their cases on average for residency and fellowship are shown. The study was from 2004 to 2009. Our internationally wide DoD electronic medical record was reviewed for preoperative and postoperative surgical notes, as well as any other clinical notes with key associated terms. As well, we included any written clinical records and operative records. The telephone survey was based on a pre-validated pain questionnaire, which was modified to include questions for recurrence, as well as if there was any clinical follow-up that was not included in our military records. There was 354 laparoscopic repairs on 241 patients. Clinical follow-up was achieved in 78% of these patients, and telephone follow-up in 73%. This resulted in a total of 91% of our patients having follow-up. Median follow-up was 30 months. Of the 241 patients, most of them were male, age 46, with a normal BMI. Of all the patients, half of them were unilateral, half bilateral, with the majority being primary repairs. The total extraperitoneal approach is the most common technique used at our institution. For intraoperative complications, we had 2 epigastric vessel ligations that were able to be successfully completed, and none of these complications required conversion to open. For our immediate postoperative complications, our rates are as shown there, and comparable to currently standard acceptable complication rates. For long-term complications, there was a recurrence for one for each surgeon, and our chronic pain patients, there was no one that required time off of work or long-term narcotics. This chart here delineates our total outcomes in comparison to published laparoscopic literature. As well, the new Mayer open group was included so you could see the standardly acceptable complication rates and compare them to specifically our recurrence rate of 0.57 and the chronic pain rate of 6.2. One key aspect of our study was comparing each surgeon, the first surgeon versus the second surgeon, for all outcomes, and this showed no statistically significant difference. As well, another key aspect was taking each surgeon and comparing his first half of cases to his second half of cases for all outcomes. This surgeon, who prepared 221 cases, only had a statistically significant difference in hematoma rate, which was 6 versus 0. For the second surgeon, in his 133 cases, comparing the first half to the second half, showed no statistically significant difference. Looking at the outcomes for all post-fellowship cases, there was no difference when comparing surgeons. This may indicate to us that the location of the expert surgeon mentorship would not have enough impact on outcome. As well, when comparing each surgeon's first half of cases to his second half of cases, this shows us that there's no initial learning curve with those post-fellowship cases performed. As the average number of cases performed in fellowship for these surgeons were 31, this is clearly well below the benchmark of 250 cases. And in conclusion, the learning curve for laparoscopic inguinal hernia repairs can be eliminated through formal surgeon mentorship provided by MIS fellowship training. Thank you.
Tiffany, I wonder if a fellowship would really be necessary, or if there was focused mentorship of that number of cases during residency, if that would be adequate as well.
Right. Actually, some studies have looked at that with saying that if there's expert surgeon mentorship, how many cases did that take? It was a Mayo study back in 2003, and they were saying about 40 cases was what they thought they averaged. And clearly, by what we could see from our study is fellowship training, but we broadened that definition to expert surgeon mentorship.
Hey, Dave McCluskey from Emory. Tiffany, I was also wondering if this begs the question as to whether our standard of 250 is a little too high for our mastery of laparoscopic inguinal hernias. What do you think based on the studies that you found here?
Thank you. I think that, with the fellowship, you have multiple other avenues of laparoscopy that you're learning hernia repairs. So having that lower number of 50, the effect may be because they perform less than the 50 that might be a standard, but they are able to hone in on the exact mastery of that because they're practicing other laparoscopic procedures at the same time.
Hi, Matt Ritter, the senior author on this paper. I just wanted to add one comment to your comment there, Rob. I think part of the fellowship training experience and reason that it changes the numbers is the experience that you gain across the spectrum of laparoscopy. So I think it's going to depend highly on the mentorship environment. What the rate of acquiring the mastery of this type of procedure is. I think for most fellows who are doing bypasses and other advanced laparoscopy, it's basically a concept of learning the anatomy, getting comfortable, etc. But but I think it certainly is achievable outside of a formal fellowship environment. But I think that there is some cross pollination of that skill set that certainly makes it easier, I think, for those who have gone through a formal fellowship experience.
Thanks, Matt. I appreciate the comment. And I think that some of the data presented speak to the issue as well, that you guys averaged only 12 of these procedures during your residency programs, and so the average resident may not be seeing the volume necessary.
Yes, Brian.
Quick question. I like this paper because it supports a theory of mine, so I always like things that support your ideas. And, when you look at the 250, you're looking at expert surgeons who had to kind of figure out the operation, and that's how they got to 250. We shouldn't all have to learn from start again, so that's always been my personal bias. But I'm wondering if this work might give you some insight on, okay, I'm out in practice. Are there hernias I should and shouldn't do laparoscopically? And I don't know if you looked into, I know you had them classified by femoral, inguinal, direct, indirect, but inguinal scrotal, BMI, recurrence, bilateral, other things that might give a young surgeon some insight into say, these aren't the ones I should be starting on.
Right, thank you. I think that with the military base of patients that we had the opportunity to be able to, have some patients with those normal BMIs, unlike your question, which is, if they're larger patients or perhaps the larger hernias in the scrotum. And with that, I think that if you're still getting the idea of formal fellowship, that would be a broad array of different subjects that would come, especially as it could be in many different institutions, as we showed a few here. And therefore, with that mentorship, it could be achieved.